Welcome, everyone. My name is Ann Siskos, and I'm a program advisor here at the Institute of Holistic Nutrition. I have a professional background in education, and I'm also a recent IHN graduate. So today's webinar being presented by Dr. David Duizer. He's let me know, we can call him David. It's Lab Diagnostics in Longevity Practice, using objective lab assessments to help clients live long and well. It is an excerpt of the upcoming continuing education course that starts at the end of the month. It's called Lab Diagnostics in Clinical Practice. It's for 7 Tuesdays, starting on June 27th, Pacific Standard Time, 3 till 6 p.m., Eastern Standard Time, that's 6 until 9 p.m., and I was speaking with the IHN admin earlier today, and we are about half full. So if you're interested, you can check out the website, or you can email Colleen if you have any questions, Colleen at instituteofholisticnutrition.com. Now, the format for today, David will be presenting his information for approximately an hour. Just under, and then we'll do a little Q&A session afterwards. So yes, please, would you leave your questions until the end? If you feel you want to just put them in the Q&A box so you don't forget as the presentation is going on, that would be just fine. So now let me introduce you to Dr. David Duizer. He is very knowledgeable and he shares his vast expertise with us today. David is the co-owner of Noble Naturopathic, an integrated clinic in Vancouver, BC. In addition to his role as primary care provider at Noble, Dr. Duizer also works as medical director at DAMY Health, an online holistic weight loss program, and also at Noble by Nature, his personal supplement line. His clinical focus is chronic disease management and integrative cancer care. He completed his Bachelor of Science degree at the Royal Military College of Canada and is a graduate of the Boucher Institute of Naturopathic Medicine. He is also a certified strength and conditioning coach. Dr. Duizer is the co-vice chair of the board of directors of the Canadian College of Naturopathic Medicine. He tells me this is taking a lot of his time right now. And Dr. Duizer obviously teaches the continuing education course that will be starting at the end of this month. Welcome, David. I'm very pleased to introduce you, and I will throw it over to you.
Thank you very much for the kind intro, and welcome everyone. Thanks for attending. I'm just going to share my screen so we can get straight away into the session. Let's have a look here. Okay, so hopefully you can see this slide, but also still see me as the presenter. Save your questions for the end, and you can put them right in the chat, and we'll spend some time discussing these when we reach the end of the session today. So today's session is a very broad overview of sort of some of the labs that we will be thinking about and reviewing in detail in the upcoming continuing education course. I love putting together sessions like this and thinking about health from a very holistic, very broad scope and lens, because that's pretty much what we're all doing in integrative and functional and really complementary and alternative medicine, right? Is we have people coming to see us and they want to be well and live long. And the way I started my practice was I was focusing on chronic disease management, and I was focusing on people who really needed the absolute most support. That was what they wanted. They wanted to live well and live long, even though they were already diagnosed. Now I've transitioned into this sort of complex practice where I'm doing optimal performance from a fitness standpoint. I'm doing body composition, recomposition, supporting people in weight loss, and 70% of my day still working in complex chronic disease, supporting with nutrition, exercise plans. And so, funny enough, all three categories, people trying to be the absolute fittest person in the room, people trying to just be as healthy as they possibly can be, and people challenged with complex conditions. They all want to live well and live long. And so I think a lot about the labs that we run. Of course, in British Columbia, I'm able to run lab work. And so all the labs we'll discuss today, we run all the time for people. But we work really, really well with the conventional medical community around here to, support with nutrition plans and exercise plans and supplement routines and things as well. And so I'm happy to see, I think there's an MD on the call today. Nice to see you, and I'm happy to chat with you about some of this. So let's get into some of the sessions today. We already had the upcoming course promoted. It's actually 8 weeks now. So we have to do 8 weeks because there's so much info to pack in, and we've opened up many, many spots for the course. And so there's always great discussion. During this course, we'll spend only half, maybe max 2/3 of the sessions actually doing slides and talking about the details, and then spending the rest of the sessions talking about the cases that I've seen and that the people in the course have seen in their own individual nutrition practices, and then working together to sort of optimize people's wellness centered around improving lab scores. So we like to look at health from a very holistic lens, thinking about pathology and disease as using a systems-based approach. So we're not thinking about just the one end organ that's impacted. We're thinking about how the whole body can influence the way that one end organ functions. And so that's the systems-based approach that we're taking throughout the whole course. It's divided up by system and pathology, but as we go through, we're talking about how stress and sleep and nutrition all impact every single lab that's actually presented. So at the same time, we're thinking about, and I think that it's helpful, and probably all of you are doing this in your own career, but thinking about individualized care and not thinking about sort of just, how someone relates to the average person in their society. We're thinking about how this person can be the best in their current life. That might mean reducing some of the environmental exposures that are specific to their home. That might be, sort of dealing with some of the complex trauma that a lot of people are dealing with now. And we've been taking that from a lab lens, right? So how does trauma impact lab work? How does toxins in the environment impact lab work? And how might some of the conventional labs actually be impacted by these sort of environmental factors? It's really cool stuff, and I just love chatting about it. And we have the greatest discussions during the course. So hopefully you'll all come and hang out with me on Tuesdays and go through this course. So we've already had a good intro for me and about the course. I'll tell you about why I'm interested in sort of like integrative medicine and thinking about alternative care. My family, like most Canadian families, was impacted by both cardiovascular disease and cancer when I was growing up. And so I'm sure most of you are in the same position. Like, why did you get into this? Well, my people I love were impacted by the same conditions that gets most other Canadians. On my wife's side of things, it's the same thing. Instead of it being cancer and cardiovascular disease, it's cancer and dementia. So those are the three things we'll discuss today: cancer, cardiovascular disease, and dementia. Those are the big keys. All the other conditions that are common in Canada sort of predispose people to these conditions anyways. Diabetes predisposes people to all three, autoimmune disease as well. And so we can think about it from that aspect. These are the three top causes of mortality in Canada here. So my CE goals, why are you here today, and why would you join the course that we're running with IHN here? Well, I'm obsessed with CE, continuing education. I'm obsessed. Whenever I do something, whenever I'm learning something, I want it to be something that I can use the following day to actually help people feel better and live longer. And so that every discussion that we have in the course, and hopefully today's discussion, leaves you with something that you can use to actually improve the lives of other people. Like, that's why you're in this profession. That's why I'm here. And so when you leave sessions like this, my suggestion is, what did I get here that I could actually use like right away? That's what you want to be thinking about. In addition, stoking the curiosity and having fun and learning new things is always enjoyable. So let's take it with that in mind as well. So let's start with a case. A client has a family medical history of diabetes and strokes. How are we going to approach this from a nutrition perspective? Thinking about that with respect to these run in the family, right? And now we're trying to make them a meal plan. So what are the kind of things that we want to see for them specifically? Well, let's think back to the family members. Who was it? Was it immediate family or was it extended family? What condition was it specifically? Did they have type 2 diabetes or type 1 diabetes? What type of strokes were they? Were they bleeding strokes or were they clotting strokes? How old were they when they happened or when they were diagnosed? That really matters. If you're not sure about the diabetes status, then you can sort of know if a person was 2 years old or under, it's probably type 1. And if they were older when they were diagnosed, it's probably type 2. When it comes to what was the mechanism by which these conditions took place? If it's type 2 diabetes, was it insulin resistance that led to this? Or did they have a pancreas surgery? Did they need some part of their pancreas operated on? And did that cause them to not be able to secrete insulin effectively enough to control this? So on the stroke side of things, if it's a clotting stroke, why did the clots build up and then break away and then find a little spot and plug it? Why did that actually happen? What is the mechanism by which they got to a place where those clots could actually occur? And then where? I put the where here. And when I'm thinking about where, I'm thinking about what is the lifestyle or what are the environmental aspects, both external and internal, that predisposed a person to these two conditions. So we're thinking about, like I said, environmental toxins, but on the conventional side, we're thinking about sort of too much exposure to saturated fat, too much damaged fats being consumed. What if they smoke? What if they have never exercised in their whole life? So if we very often see people who come in and they have exactly this history. My parent had a stroke when they were 60. And then we go through this and it turns out that they smoked for 30 years and never exercised a day in their life. Does that mean that this person has the exact same risk? Maybe not, right? Like maybe not, maybe there's something else going on. But if a person was really, really healthy and they had a cardiovascular event before the age of 40, maybe there's some other reason this could have occurred. Now, we can also think about it from the lens of like, how was a person raised, right? Like, so were they raised around the cigarette smoke and were they fed the same diet that that family member had? These are really important questions that a person could be considering. And then we have the just pure genetic implications. Some people absorb, for example, cholesterol very rapidly. They have hypercholesterolemia that's genetically induced. Some people make what's called LP little a, lipoprotein A. It runs in families. Some people are just prone to chronic inflammation. Some people have a genetic predisposition to Alzheimer's because of the ApoE gene presentation. So we can think about it like from a pure genetic standpoint. But I really think going through family medical history first is a really important part of this. And so let's say we did that with this person here. Now we have to make our considerations. We want them to live, remember, long and really, really well. So what can we do for them? Well, the first thing is, what did they bring in to the actual visit with us? What type of labs are they bringing in? And so we sort of tip the kind of like typical yearly labs that we commonly see that are conventionally run here in British Columbia for people who see their physician regularly enough would be listed on the right there. The lipids, they get their cholesterol checked. Fasting plasma glucose, they have blood sugar checks. Hemoglobin A1C is a proxy for average glucose over 3 months. Thyroid stimulating hormone will have what's called the TSH tested quite regularly around here. CBC with differential is complete blood cell count with white cells. Most common lab that you'll see in your nutrition practice ever will be this one. And then liver enzymes and kidney function tests. They're very commonly run. This sort of panel is, the reason it's run so frequently is because it's ridiculously important. It's ridiculously important. And anyone who has a dogmatic approach about these, saying that we should be living and dying by these from a medical standpoint, can get themselves in a little bit of trouble. So I try to stay humble about all of them and do my best to follow the evidence. And so we'll discuss a little bit about that today. So let's think about this situation where there's a family history of diabetes and cardiovascular disease. And now we've seen all these conventional labs run. What can we then do for the client in front of us to help them maybe optimize these labs? That's probably the reason you're here. And the reason that many of you will take the course is that you're looking for optimal for yourself, your family members, and your clients. And so we, in the course, go through what is optimal for each of these, for each individual person, or do our best to find those numbers, what they actually might be. And so we'll talk a little bit more about that today. So if we think about that from a conditions-based approach, right, like we want to prevent heart attacks and strokes, and that is to say that we want to prevent the plaque from building up in the arteries. We're all going through this process. It starts when you're very young with something called a fatty streak. Cholesterol and other substances are bound within a plaque, within plaques in the arteries, and they build up over time. Dementia. There are a few different types of dementia, and they have very similar predisposing factors. For example, inflammation, high blood sugar, and plaque buildup in the arteries. All of these can predispose a person to dementia. But like I mentioned already, there are genetic risk factors as well, like the ApoE gene can code for an increased risk. And then cancer. The difficult thing with cancer is that there's so many different types. 200 different types of cancer, and you can see a wide variety of them if you're running like a complex chronic disease practice, or if you're running any really nutrition practice and you're, sort of looking to help people who are going through conventional therapy with their nutrition programming. My goodness, you can see blood cancers, you can see solid tumor cancers, nervous system cancers, you see a bunch of different things. And they're all very complex, and today we'll try to make it as simple as we possibly could. Then we think about this from like a systems-based approach. This is the most exciting bit. My favorite way of looking at the systems-based approach, and what I'm doing mostly in clinical practice these days, is thinking about the lung-heart-muscle axis, which really is the distribution of oxygen from the outside world to the mitochondria in the muscles to make energy. This lung-heart-muscle axis can be disrupted by many factors, including all of the ones that we'll talk about today. The reason I'm so passionate about this is because in my office, we're mostly known for testing physiology. We do metabolism assessments at rest and during exercise. So we do resting metabolic rate measurements, and we do VO2 max assessments on both the bike and the treadmill here. So we're thinking about how many calories a person can burn at rest, which is to say, what is their energy output in a rested state? Or energy consumption, I should say, consumption and production of actual ATP. And then how fit can a person actually be? So we take the baseline fitness, and then we do nutritional programming and exercise programming to help them become fitter over time. And that means to improve their VO2 max. You'll see why later in the session today, why we do that. The key focus of this whole thing and why people take the course and all this stuff is really like, how do we optimize the oxygen consumption by the tissues? Well, the oxygen needs to get into the lungs, and then it needs to get into the bloodstream, and then it needs to go to the heart and be circulated to the tissues, where it then needs to be distributed from the blood vessels through the lining and into the tissues, and then used by the mitochondria to make oxygen in an aerobic state. So when times are easy. That's all influenced by how effective the cells of the lung are, right, at pulling it in, how good the muscles of respiration are at expanding the lungs and bringing in as much air as possible. But then how efficiently the heart actually pumps blood, right? Like the heart's a muscle, and it's got to be efficiently pumping, which requires it to get its own blood flow too, and nutrients. Then there's the electrical capacity of the heart, right? Like the nervous system controls it. And then when we get to the blood vessel lining, like that blood it's got to travel. First of all, we got to package up the oxygen with nutrients, for example, bound to iron. It has to travel through the blood vessel system. And if there's not a ton of plaque buildup, then it can get where it needs to go, but then it needs to be distributed at the end organ, right, to the muscle tissue, which requires electrolytes, which requires not to be a ton of oxidative stress in those tissues. There can't be a bunch of damage in those end organ tissues, where then it's distributed to the muscles, where the actual metabolic rate is then controlling the production of energy. And so that requires the thyroid to be functioning properly. The mitochondria can't be toxic with the byproducts of environmental toxin exposures. They can't be burdened by a lack of nutrients. And then they have to have all of the required nutrients, for example, to run what's called the Krebs cycle and electron transport chain, which requires a really healthy digestive function and proper detoxification by the liver and circulation to those tissues. So you can see how we're thinking about the nervous system, the immune system, we're thinking about the liver, kidney, GI system, the absolute metabolic system, like the production of energy and the regulation by thyroid hormone, but then the cardio, lung, and muscle axis. So this all, when you put it all together, it looks super complicated, but in the course, and today what we'll try and do is separate it out and talk about what labs could influence each part of this chain. It's kind of a fun way to think about it. So let's first start by thinking about cholesterol, right? Because strokes and heart attacks are the main things that get Canadians, the main causes of mortality here, the main things that get Canadians. But there's a ton of debate and controversy around what is good LDL, right? And what is good HDL, and what is a nice, what is the perfect lipid panel? What I'll say is that total cholesterol and LDL cholesterol, they're independent risk factors for cardiovascular disease. And if cardiovascular disease is the main thing that's getting Canadians, we got to take them very seriously. That doesn't mean we need to be fully dogmatic about them, because you'll see that your local lab will publish something called the risk ratio, right, which looks at total cholesterol to HDL. HDL, high density lipoprotein, is the detoxification molecule that the liver makes to go and clean up the arteries and take the cholesterol back for recycling. So if there's lots of HDL around, then you know what? Total cholesterol may not matter as much as it would if HDL were very, very low. And that's very well documented. If you're running something, what we teach in the course would be something like a Framingham calculator or ASCVD calculator. These are risk calculators for cardiovascular disease. They take into account HDL. If HDL is very high, the risk of cardiovascular disease is definitely lower. And so we take that very seriously. But now we have access to new metrics, right? Like you'll see these if you get this lab and you have a cholesterol, for example, that's not in the normal range, you'll see a write-up below it that references the Canadian Journal of Cardiology a couple different times, suggesting other metrics to be looking at if the risk is not very, very low. And one of those metrics would be ApoB100, which is a protein that's present on all lipoproteins and is a good proxy for LDL particle number. So we run something called an NMR test, which you'll see a little later today, which looks at the total LDL particles, but it's not necessary. ApoB trends exactly with it, which is why it's not common here in Canada. ApoB is so much less expensive. So that's looking at, both of those tests are looking at how many actual particles of this transport protein are present in a sample. Not how much cholesterol is being carried around, how many particles. And the particles actually are a better proxy for risk, right? Because they can be quite sticky and they can become oxidized very rapidly. And so looking at ApoB100 is a really good thing to look at. And we see that all the time with the family doctors in our neighborhood, around the Fairview neighborhood in Vancouver here. Many of the family doctors just run ApoB now instead of doing this whole panel, which is kind of cool and interesting to see. And so we focus heavily on that one. Then we have LP little a, lipoprotein A. This became famous sort of like in the mainstream media after one of the coaches from The Biggest Loser show on television had a cardiovascular event at quite a young age. Turns out his cholesterol was okay, but the LP little a was quite high, which is another lipoprotein that is genetically demonstrated. So it runs in families and can increase the risk of plaque buildup in the arteries. So lipoprotein little a, no current treatments, but helpful to know, because if things are high, then you can optimize everything else that's being tested to go for absolute perfect levels to try to reduce the genetic risk that a person is experiencing. Then we have LPPLA2, which is a really interesting marker. It's an enzyme test for a marker that only goes up when there's inflammation in the arteries, really. It's really, really cool. It's not commonly run currently because it's not available at the moment. It's not been available for 4 or 5 months, but it's an inflammation test for the vessels. Whereas when we run something called C-reactive protein, which is a more broad assessment for inflammation, we may not know exactly where that's coming from. Whereas if we're able to run something like LP-PLA2, we can know that that's mostly in the vessels. So it's a bit different than typical CRP testing. Really, right now, that's all I have access to is CRP, and often for me in my little practice here, that's enough. So in the course, we go through how to sort of look at that and optimize. So why the heck would we run all these, right? Like, why would this be done in a longevity assessment? Well, if someone has low HDL and high LDL, high total cholesterol, there's a risk of more cholesterol being deposited into the plaques that are already present in the arteries. And you know what else gets stuck in there? Things like calcium get stuck in there. Things like lead get stuck in there. Oxidant markers, oxidants from the environment and from the byproducts of human metabolism get stuck in there. And all of this can drive a low-grade inflammation cascade that smolders over time. It smolders, smolders, smolders. I've taken this image from the pulse test that's offered by Life Labs here in British Columbia. It's the protein unstable lesion signature. I like this test. It's very expensive, but it's rather unique in the sense that it's looking at these inflammatory markers that are present in this smoldering heat around plaques. Right, so it's very specific. So you can see some of these here, right? Like you can see the CTAC, you can see HGF cell proliferation, you can see apoptosis marker, the body trying to clean it up. You can see angiogenesis marker, the body trying to improve the vasculature. You can see the chemotaxis, which are the attractant molecules. They're telling the immune system some bad stuff is going on in here. So the pulse test kind of looks at all this. But and then it presents like a 5-year risk of cardiovascular disease, which is very cool. But what I take from this and what I typically like to tell clients and patients is like the most important thing here is that when plaque does settle, which it does, it can then be damaged by our own byproducts of metabolism. And then the immune system sometimes might not be able to clean it up. So we do things to try to help the immune system become more efficient at cleaning it up. Like we help people sleep through the night. We provide them lots of healthy nutrients from the nutrition plan. We get them exercising in a really, really healthy manner, like a heart healthy manner. We prescribe Mediterranean diets, and we give anti-inflammatories, for example, and other sort of nutrients that help with tissue healing and blood flow, so that we can try to prevent this plaque from then breaking away and traveling to a smaller area, or to try to prevent this plaque from building up and closing off the whole vessel. So that's the key focus. And we like to use lab work to try to see where the low-hanging fruit is, like where is the target that we want to be working mostly on. So the key targets, I put this here because it's kind of interesting. This is the LDL particle test that we run from the States. Like the local lab here just outsources it to the US. It does LDL particle. Like I said, I like ApoB a little better because it's cheaper. But the interesting thing about this one is it does the size of the LDLPs. Smaller LDLPs are a little stickier, a little more dangerous. And so if someone has a lot of these, then they may be the person who we want to suppress that LDL, right? Like they need a statin drug if the natural approaches, the nutritional and supplemental approaches don't work. Then what we can do is then we can just use ApoB, or we can just use LDL cholesterol to look at it long term. I think that's a rational way of looking at this. It can be low cost if you keep that smart approach, like just do this once and then have a look. But you're reducing the risk because you know that small LDL particles are very sticky and we can easily suppress them. And so we may want to actually suppress them if we see something like this. Then we can take, for example, the calculators very, very seriously. The one comment I'll make about the calculators, it seems as if artificially raising HDL through supplements doesn't lower the risk of mortality. And so when we raise HDL, that detox molecule for the vessels, that's got to be done through exercise. That's the main way that is known to actually lower the risk of cardiovascular events, but also raise HDL. So just artificially boosting it up doesn't really do much according to all the evidence that I have seen. So this is kind of cool. So that's cardiovascular disease in a nutshell, right? Like we're all building plaques. Let's make sure they don't get damaged. And then let's make sure they don't get super inflamed and break off and travel somewhere or build up enough to block that one spot. And we want to take nutritional approaches to reducing that. So Mediterranean diet, for example, so lots of studies have been done to show that that's a very effective way of keeping the vessels very healthy. From a lung, heart, muscle axis type scope, right? From a system scope, the oxygen is getting into the blood cells here, right? And it's traveling. But if it can't be distributed along the lining because there's too much plaque building up, or because the lining is damaged, right? Arteriosclerosis. So the lining is actually damaged and become inflexible, then the distribution of oxygen might not be as efficient. And so we're just thinking about the cardiovascular system, like we got to keep the vessel lining very, very healthy. Then we think about cancer, right? Cancer is really difficult to manage, to build a prevention plan around labs. Like it's really tough. So what do we look at with cancer, for example? We know that obesity predisposes someone to cancer. We know that that people with elevated blood sugar, so people with diabetes, are predisposed to cancer. And we know that environmental pollutants cause cancer, like cigarette smoke. So we know these things, they cause cellular damage, and we should try to prevent them from occurring. But then we have 200 different types of cancer to sort of parse out. So what we go over in the course is not really optimal levels for cancer labs. It's not that helpful, right? Like thinking about tumor markers, for example, that was see on here, like CA125 and CA15-3 and CEA. Those are not helpful. They very rarely are something that oncologists are super thrilled about running or excited about tracking. What's helpful from a cancer standpoint is making sure that the body is in such a state that cellular damage is not commonplace. And if it does occur, it's fixed immediately because the immune system is so efficient at its job. And so our role, and from the nutrition standpoint and sort of from the lifestyle standpoint, is to be supporting an extremely healthy immune response. Like the immune system needs to keep us safe. This is why people are doing fasting protocols and people are doing, sort of like very restrictive diets, right? They're trying to give their immune system what it needs to be most optimal. And so we talk a lot about that in the course. We don't talk a lot about these labs. So lots of controversy around the use of sort of like PSA and prostate cancer and tumor markers in general for tracking and looking at labs. But one thing I'm very interested in is lactate dehydrogenase, LDH, as a marker of anaerobic metabolism, right? Cancer cells love to switch their metabolism. They start making energy very efficiently without a ton of oxygen. And we see a lot of lactate dehydrogenase going up, and it's kind of an interesting one, and very inexpensive lab to be tracking in many different types of cancers. But we go through all these, of course, and try to optimize for these. So from a longevity and health span standpoint, if cancer runs in the family, or if a person is worried about cancer, we have this opportunity to talk to them about the difference between healthy cells and cancer cells, right? This is a really cool slide that shows the difference. Cancer cells, they divide uncontrollably, which means the immune system is not slowing down their division, or at least managing it. Their internal workings as well are not managing their growth and division. So they should have their own mechanisms for maintaining that equilibrium. So what if those mechanisms are broken? Well, that also is because of cellular stress for some reason or another. Remember, we've already touched on oxidized lipids. We've already talked about cholesterol that's been deposited and then become damaged, and the immune system's having a hard time fixing that damage. That's one thing that can impact cells, right? Oxidized particles. And so we think about that. Then we think about the variations in size and shapes of cells. So they've lost their ability to maintain their size and shape. Then we think about the nucleus that's larger and darker than normal. They look a little different than normal cells. And we think about the abnormal number of chromosomes arranged in a disorganized fashion. So the actual equilibrium that's maintained within the genetic data here has been disrupted. So cancer is any one of 10,000 or more different types of different potential DNA breaks. Right? So changes in the genetics of a cell has made it such that it doesn't have a proper shape any longer. It's a bit weird. The nucleus is a bit huge sometimes, and it's dividing and growing without the immune system even seeing it, or without its own properties being able to shut it down, its own biochemical reactions triggering this cell death. And then a cluster of cells without a boundary. So we have a cluster of cancer cells that are difficult to actually see where the actual boundary is. It's kind of interesting. So what would lead to all this? Well, we started with one thing. We started with the DNA damage. There's something that caused this cell to then divide rapidly and grow. And so what are some of the things that it could cause that? Well, we know for sure that environmental pollutants like cigarette smoke, but then we also think about the stress on the cells, maybe from high blood sugar, right? Sugar is damaging cells constantly. It's trying to get in, but it's not getting in, and it's causing this low-grade chronic inflammation that is quite damaging. Think about how all these things might impact. And then we look to labs. So now we're not looking at cancer labs. We're looking at blood sugar control. Now we're not looking at cancer labs individually. We're looking at inflammation markers like CRP. Now we're not looking. Now we're looking at infectious cause, right? We're seeing things where we're thinking about viruses and bacteria and parasites as potential tests here for someone who's trying to reduce their risk of these very dangerous conditions. So that's kind of an interesting systems approach. Yes, we need to get lots of oxygen into the tissues, but we also need to think about reducing those stressors on the system so that we don't get that one piece of DNA damage that we can't get ahead of. That's how I like to think about it. And then finally, the growth signals, right? So if we get in a situation where someone can't clear all their estrogens, or they're making too much toxic estrogens, or if they're, for example, taking too much testosterone or too much DHEA, or some of these anabolic hormones that actually cause cells to grow, then there could be a potential for some bit of DNA damage that propitiates that approach, that response. So we think about the growth signals, right? Insulin from the carbohydrates, hormones like estrogen and testosterone. For example, in prostate cancer, we suppress testosterone. In breast cancer, we suppress estrogens, for example. These are approaches that limit the growth factors that could potentiate that abnormal growth that's occurring. And then we think about the stressors, right? We have to think about reducing environmental load. And part of that might simply be the person's own internal stress responses. We talked to an oncologist a couple of years ago. We were working with a person who had a very, very healthy lifestyle, very fit person, healthy overall, labs all looked good. And we said, well, why do you think they got cancer here? Like, no genetic history, it's all been good. And they talked at length about the chronic stress the person was under. And I really resonated with that. Like we've seen people here who have been healthy metabolically, but their cortisol has been incredibly high, the stress hormone. And, potentially, or the wear and tear on the body from that internal stressor over time may predispose them to uncontrolled cell growth. So that's a little bit of a functional lens. Then we think about the third condition-based approach here, dementia, right? Like dementia, a common cause of mortality. What are the actual causes of dementia? Well, you can take a step back and think about the cardiovascular system and the cancer responses before even thinking about the brain. We need to get oxygen to this brain for it to function properly. But if there's sluggish blood flow or too much disruption in the distribution of oxygen to the brain, that's going to be a problem. If we get in a scenario where there's chronic cell damage from some toxic internal or external exposures, then that's going to cause cell damage. The nervous system is not exempt from cell damage. And then we think about, the genetic risk, which we've been thinking about the 2 copies of ApoE gene. We're looking at a 2, a 3, or a 4. And a 4 predisposes someone, a copy of a 4 predisposes someone to the risk of dementia. We know that sleep is really important in brain health, and keeping things like B12 normal is also very important. So what do we look at conventionally? We start with the CRP, that chronic low-grade inflammation. Then we think about the B vitamin deficiency and the buildup of something called homocysteine we spend a lot of time on, that can occur and can be easily reduced by supporting B vitamins. Then what about nutrient status? Like the nervous system has vitamin D receptors, just like the immune system does. Low levels of iron impact that lung, heart, muscle, or we could say lung, heart, mitochondria systems-based approach here. If iron's low, then we're not getting adequate amounts of oxygen to the tissues, which causes disequilibrium. And then B12 causes dysfunction in the nervous system. And then we think about sleep studies, like sleep apnea, for example, is predisposes someone to dementia. Now the heart of the session. The heart of the session is that the fittest, strongest people live the longest. It's well documented. The people with the highest VO2 max live the longest. The people with, there are anomalies, right? There are people who have really, really high levels of VO2 max who pass away early, but let's be fair here. The people who are the fittest aerobically have the best lifespan and also have an excellent health span. They live well into old age. Same thing with the strongest people. We know grip strength is a good proxy for longevity, but the ability to get up and go at the age of 90 is really, really, really important. So we think about strength, and I should say balance at the same time, as really good proxies for longevity. The fourth condition here we're not going to talk about today is fractures of the bone. Fractures in old age increase the risk of mortality significantly, and being stronger is helpful in preventing the risk of fractures. So let's break these down a little further. The first thing is that VO2 max is the max amount of oxygen a person can consume in the tissues when they're giving it their all during a cardiovascular output event. So we do something called a ramp test here, where we're looking at how much oxygen can a person consume when they're exercising maximally. And it's measured in milliliters of oxygen per minute time divided by the kgs of body weight. And I got really excited about this back in 2019 because the American Heart Association had published in 2018 that VO2 max was better than blood pressure, blood sugar, and cholesterol for predicting longevity. And then they said in a little line underneath, and it can be tested in office. And I thought, wow. And so I bought a mobile device right away, and we've been testing VO2 max ever since. Still thinking, of course, about blood sugar, cholesterol, and blood pressure, but focusing mostly on optimizing fitness for longevity. So how do we optimize fitness? Well, we have to have enough muscle to consume the oxygen, and the mitochondrial capacity within the muscle has to be increased. Cardio increases that, but you have to have enough muscle as a foundation. So we measure muscle mass. But then it's milliliters of oxygen per minute consumed. So we think back to the lung-heart muscle connection. It's got to come in through the lungs and be distributed by the heart to the tissues where the mitochondria have to be so efficient they can consume it when they're under stress, like fast running on a treadmill or pushing it hard on the bike. That requires there to be not a ton of inflammation, not a ton of oxidative stress, good blood flow to the tissues, adequate nutrients to run Krebs cycle and electron transport chain. So we can be testing for toxicities, blood flow, cholesterol buildup, damage from blood sugar. We can be testing for hormone status, because you have to have a certain amount of testosterone to have the muscle mass, right? You have to have a certain amount of estrogen to become sensitive, to stay sensitive to carbohydrate. We can be thinking about digestive wellness, right? We can think about the absorption of nutrients and there not being a significant amount of inflammation in the small intestine where nutrients are mostly absorbed, or in the colon where most of the detox in the stool is forming, right? The stool is clearing out toxic metabolites and preventing them from being reabsorbed and sent back into circulation. So I wouldn't be a good naturopath if I didn't talk about the digestive tract, but it's really important in this whole system as well. So then we think about like functional labs. How are we going to be, we clarified the conventional typical yearly labs run, but then we think about, okay, what are the most important things? Yes, those help us to work on the most important things, but what are the functional tests that we could do to help people become fit and strong? Well, we can make sure they're not too stressed and that they have a normal cortisol release. High in the morning, low at night, little bumps in the day with meals. This is a really important hormone. It has to rise in the morning to wake a person up well, and also to help them keep their inflammation low. But then it's got to go down at night so that melatonin can flourish and do its thing and the body can get full rest. If this graph is not occurring appropriately, then there could be some negative implications from this sympathetic hormone, right? So we think about cortisol. Then we think about the daily flux of carbohydrate. We talk about continuous glucose monitoring in a diabetic population and continuous glucose monitoring in a non-diabetic population looking to live long and well. Does that mean carbohydrate is flat all the time and insulin is flat all the time? Maybe not, because we need insulin to make good muscle. But for sure, the levels are not going to be too high. If they're too high, that sugar is going to damage the blood vessels. The pancreas is going to get tired over time of having to secrete so much insulin to maintain this. Then we think about functional hormone tests. Have a look at a sample Dutch test here. We spent a whole session last time talking about hormones, both female and male, and going in detail about conventional and functional tests. It's really, really cool to think about the 3 different types of estrogen and the different things they do, but also their metabolism, like whether or not a person clears them effectively or whether or not they're passing in the bowel movements, right? Like we got to get rid of the byproducts of estrogen metabolism. Very cool stuff. Then I don't want to harp on environmental exposure too much because I'm not the resident expert in our profession about this, but I do think it's important to make sure people don't have a significant body burden. For example, we've had to call poison control a couple times here for very high levels of mercury. But think about how mercury and arsenic can damage the nervous system, and arsenic and lead can damage the nervous system and settle into the bones and cause chronic oxidative stress. It's the same thing with with chronic infections, right? If people have a gum infection, we know that they're predisposed to cardiovascular disease. If people have a chronic infectious disease like a hepatitis, a liver infection, then they will be predisposed, for example, to liver pathology, liver cancer, and liver cirrhosis. So other possible external or environmental toxin tests, and the ones that we will really talk about mostly in the course, will be things like glyphosate, which is like a preservative for plants, or anti-weed, right? Mycotoxins, the toxins made by mold, very, very prevalent here in Vancouver, or quite dry right now, but mostly a rainforest type of climate, and tons of people are burdened by the toxic mold that they're exposed to. Infectious disease, and think about infectious disease from a digestive standpoint, right? Like if people have chronic digestive infections, conventionally, there's often not much that can be done or would be done, right? We try to keep the rest of the system healthy, but from an integrative standpoint, maybe we could be thinking about optimizing digestion and making sure that these bad guys aren't living in them. Then we think about a little bit more obscure testing and maybe sort of on a bit of a fringe here, but looking at neurotransmitter assessments. We know that the key mechanism for the happiness generated from serotonin reuptake inhibitors is actually the serotonin. Keeping serotonin around longer makes people feel better. So what about the amount that's in free circulation? Well, we don't want it to be super duper low, and we don't want excitatory neurotransmitters like glutamate and histamine and epinephrine to be very, very high all the time. So in a chronic stress state, it's kind of nice to see those sometimes. So we talk about bringing equilibrium, bringing balance to the nervous system from a neurotransmitter standpoint. And finally, we've got the functional assessment, right? With already talked about strength, but what about mobility and balance? Having energy is an important aspect of living long because we need to be social and we need to be moving. And therefore, our immune system has to function. We can't be sick all the time. And we have to keep pain down. We can't be in pain all the time. So we have to think about labs that are helpful to improve these, right? So on the energy side of things, we have to sleep through the night, yes, but we also have to have adequate levels of B12 and iron and vitamin D. I think those are very important labs. From immune function, we're thinking about vitamin D, but we're also thinking about zinc and other minerals and vitamins that are important for immune function. And then from a pain reduction standpoint, really thinking about the repair. Like, why is the tissue chronically painful? And basically, like, why is the system not healing that tissue fully? And then one of my favorite assessments is looking at the hemostatic model of insulin resistance. Hemostatic model assessment of insulin resistance, looking at a fasting insulin instead of doing an oral glucose tolerance test and doing insulin tests multiple times, just looking at a snapshot of a fasted blood sugar with a fasted insulin to see what kind of work the pancreas is doing in the morning to keep blood sugar normal. That's kind of an interesting assessment as well when you have people who are really trying to be healthy, like not getting diabetes, not getting cardiovascular disease, and not having any cellular damage or any damage to the nervous system in the brain. So what about finding optimal levels and actually doing some goal setting? What could we be doing in our practices to achieve this? Well, I think it's been pretty clear about what my approach is, or what a typical approach would be to lab assessments and longevity, but we didn't talk at all about optimal levels. It's very, very, very tricky to think about optimal levels. So in the course, we talk about how the levels are generated, right? Very commonly, most of the levels that you'll see in your conventional labs is like the average person in your region would be the middle of the reference range, and then 2 standard deviations from that mean would be the top and bottom end. And that doesn't mean that being within those levels is actually optimal for a person. Some of the labs will have like pathology, cutoff points where if it's here, it's a pathology, if it's here, it's not. But many are simply, what is the average population? And my understanding is that that's why we've seen the liver enzyme reference ranges increase over the years in our region, is this that the average liver enzymes for people is a little higher now. But that doesn't mean it's optimal. So what the heck is optimal for people? Well, we have certain thresholds that we want to stay under. You'll see in a CRP test, in an inflammation test that the lab will write, if we're thinking about cardiovascular disease, we want to keep the CRP below 2, because if it's above 2, it increases the risk. Well, does that mean being much lower than 2, like down at 0, is optimal? Not necessarily, because we need inflammation, right, to heal from stuff. But for some population, focusing on keeping that CRP as low as possible would be a decent target. If they have really high blood pressure and really high cholesterol and high blood sugar, we need to make sure they're not inflamed. That's what a lot of people are probably seeing you and saying, if they have high cholesterol, but they don't have a ton of inflammation or oxidative stress, maybe their vasculature will not be impacted by that high cholesterol. Fair statement. So we have to think about how we can look at this holistically. So what would be an optimal level on the hormone side of things? Well, if we're thinking about testosterone, for example, too high levels are associated with a slight risk, a slight lessening of longevity, life expectancy. But too low levels can predispose the person to being weak and having poor blood sugar control. And so what we typically like to do is think about the level at which a younger person might have and maybe shoot towards that. Not too much higher than that, but decently close to that to go for optimal. I hope that makes sense, that there's like this sort of little dance that's done when determining optimal levels for a person that we like to sort of take a rational approach towards. For example, on the blood sugar side of things, when we're thinking about A1C, the average blood sugar over 3 months, first of all, there's some differences between individuals. If their red cells live longer than 100 days, the A1C might not be as valuable as someone whose red cells live 90 to 100 days or however long they typically would live. But for the general population, keeping the A1C, of course, below 6.5 is very important. But is there a longevity benefit from going from 6.5 down to 5.5? Maybe not significant. Maybe not significant. But there's a big difference from going from a 10 down to a 6.5. for me personally in my practice. I want to see people with normal levels of blood sugar control. And this is the kind of lens at which I think we should be approaching this. So, for example, for goal setting, my favorite thing to do is to set a timeline that's rational. Most timelines for retesting, 3 months, very much most. Even when it comes to fitness and strength, 3 months. When it comes to cholesterol, 3 months. When it comes to inflammation, we might be thinking shorter, like 2 to 4 weeks. But blood sugar, A1C, it's got to be 3 months. Insulin sensitization, 3 months. Usually we're thinking about 3-month goals. Let's get a percentage reduction in 3 months and see if that correlates with a reduction in risk of mortality. And that's my favorite way of looking at it. So I'll leave you with the statements here, this holistic approach. This is a framework to help people sort of get started on their optimal health and longevity journey, right? Lung, heart, muscle axis. I hope I leave you with that. Systems-based approach, conventional labs, most important first. Cholesterol, normalized, not zero, but not sky high either. HDL, high because of exercise. Inflammation, CRP low. Blood sugar, tightly controlled. Liver enzymes, kidney function, normal. Then reduce exposures both externally and internally. Keep stress low and sleep through the night. Keep the environment as clean as possible. Okay. This is my information. If you want to connect with me anytime, reach out, send us go to our website there at noblenaturopathic.com and send us a message anytime if you have further questions or you want to chat about anything. I just love talking about nutrition programming and the impacts that nutrition programming can have on labs and how it can really help people feel good and live long. Any questions?
David, wow. I just have to say, your enthusiasm is so contagious. I thank you greatly for the informative talk. Your discussion about VO2 max and I guess it was strength as being an indicator of, I think it was determining heart success or heart disease. That's also interesting to me. I do have a background in physical education, so this is wonderful. Okay, so let's go to a few questions. I see one that's in the Q&A already. If anybody else has more, please put it in the Q&A. I'm going to check the chat as well. So our first question, David, what are your thoughts on LPPLA2 versus HSCRP?
Excellent question. I love LPPLA2, but it's too expensive. And there's a bit of controversy around the actual enzyme level versus one other metric that's measured with it. So I'm not fully an expert on it because I haven't had enough exposure. I've ran it 3 or 4 times in practice before it was stopped here. I think it was stopped in January. I've wanted to run it a couple more times, but it's so much more expensive than measuring CRP. And CRP has, I believe, more data around it, especially on the cardiovascular side. So I've been just doing CRP. And the good thing about it being low cost is you can run it multiple times, or you can run it more frequently, but it's just not specific. So if someone has an infection or has an injury, CRP won't be useful because it's just high because of those two things. If they have autoimmune disease, it's high, and we can think about keeping it lower to protect the heart and cells, but difficult to fully get down because it's driven by the disease. So there's a ton of nuance there, but I love measuring CRP. And if I had access to LPPLA2, I would do it more often and I would get better at it. Thank you.
Great. Thanks, David. Another question here. What is the strategy under the holistic point of view to suppress the small LDL for sticky small particles to reduce the risk?
My strategy is to lower LDL. That's my strategy. So if I do a test where ApoB comes up high or small dense LDL particles are elevated, then I suppress LDL. So I would be taking an approach that would be natural first for 3 months. And then if it wasn't a huge success, usually we can get a 20% reduction from the natural approach, and that's often enough. If it's not a success, or if the 20% reduction is not sufficient, then we would suppress with medications.
Okay, great. Okay, when is it too much testing? What if a client comes in with pages and pages of testing, wants to get all the tests done? Sometimes this person is saying they get so caught up in the numbers associated to the diagnosis that we lose focus on what's important. Where do you start first?
Excellent question. Happens all the time. You start with feeling good. What are the things we need to do to feel good? Then we have to think about the implications of these results long-term. I have an example case of someone who's young and healthy who just did a series of functional tests, and we found many, many things. So I consulted with the PhDs at the lab, and their suggestion was that these are not issues right now, but if we don't fix them in 20 years, they will be. Now, when you say that to a person, it can be very scary. And we don't want that. We don't want to increase their cortisol because of just a simple discussion we're having about longevity prevention. But they ran the labs for a purpose. And now we can approach it very humbly and very rationally about the long-term implications, just the well-documented ones, and take steps that are supportive of long-term wellness. So, for example, in a case like this, we start with the conventional ones. If cholesterol and blood sugar and inflammation and kidney and liver function and thyroid function are all good, then that's all good. Right now, we're fine. If they're feeling good and their markers of health span, feeling actual good in the moment are good, then we don't have a ton of concern. But if we catch a bunch of things in addition that are functional that are coming up, you might see this with like food sensitivities, for example, which is a really difficult one to think about, then we don't have to be dogmatic about it. Like they're not going to be in trouble right now. But lowering the reactions or lowering the environmental exposures or helping heal the tissues that might be showing some need could be valuable. So stepwise approach, conventional stuff, feeling good, and then picking away at things about that would help with their long-term wellness.
Okay, great answer. Because I know that is the case. A lot of people are so wrapped up in the labs, they've forgotten to zoom out and look at, how they're feeling, what the symptom pattern is.
Yeah, so you could start the conversation by saying that you may have learned these from YouTube doctors, and they're awesome people and they know so much, but it's not individualized care. When you hear someone talk on a podcast about all the amazing labs that are out there, when someone watches this video, they may want to run all these tests. That might not be appropriate for a person and may cause more confusion, but also the person presenting isn't thinking about them individually. And so you take it from that lens too, that they may be presenting it as something that's make or break for health span, but looking at the data individually and thinking about it for them as a person is much more important.
Great, thank you. Robin wants to know, what's the mechanism of action behind increasing HDL through exercise?
What's the mechanism of action? Great question. Yeah, I'm not 100% sure. When we exercise, the liver gets better at making this protein, and then it cleans up the arteries. Yeah, great question. I don't know why the liver does that, but it does.
Yeah. Have we got more questions? I don't see any more coming up in the box. So I will ask you one. So you mentioned very early on in the talk about stress and its role in multiple health conditions. I'm wondering how often you test and what what tests do you run? Is it just the, full day cortisol testing that you do? And then the second part of it is, if you're seeing stress for your client being a big part of their illness, what are you doing to tackle that?
Can you say the first part again?
Yeah,
Introduce the question.
what way, how often are you testing for stress, and how are you testing it? Is it just the cortisol testing, or what other tests are you running?
Oh, great question. Yeah, so I only test if it's going to change the way we're treating. So when it comes to stress, for example, L-theanine has great evidence for reducing anxiety and worry, fear, doubt, and worry. And so if we're not having to think about improving sleep, for example, or we're not thinking about sort of the fluctuations in stress response during the day, there's no real pattern towards it, and they want to get some results right now, we don't need to test. Like, it's not important. But if it's been going on for many, many years and it's impacting their sleep, impacting their way of being in the world, and we want to consider specific cortisol reduction at certain times of day, I like to test, because suppressing cortisol when it's not, like, the symptoms of low cortisol can feel just like the symptoms of high cortisol. So we don't want to suppress it unless we know what the numbers are. So if we think we need to suppress it, we should test. That's how I approach it. And then other assessments for stress, if someone is has coped with anxiety and depression for many, many years and not had any success, there's labs like the neurotransmitter test that can be very helpful in finding the balance between sympathetic and parasympathetic and improving the parasympathetic response. And then there are tests, for example, like genetic tests for which medications will be most effective for a person. That could be interesting to run if we have a definite need for medication because the person is at risk to them or their family. So, we have some other options that could be considered, but as a naturopath, we just love cortisol testing. So we run a lot of those.
Great, thank you. Are there any more? Oh, I think maybe one just came up. What is your idea for people who want to lose weight on the keto diet and their LDL goes up?
We talk in the course about doing a cardiovascular risk assessment, telling them what their risk is. So if it goes up, let's say, for example, the LDL goes up, but they have very low blood pressure, their triglycerides are well managed, they don't have diabetes, and they're young, then and they have adequate HDL levels, like the HDL goes up with it, then you'll see the risk will come back very low. And I put that on a graph, right? Like if the risk is, the 10-year risk is 5%, then you can line up all the people and tell them how many people would pass away of a cardiovascular event if they changed nothing within the 10 years, the 10-year risk. So and then we can say, if you don't do this, your risk is going to be down here. If people are doing this to lose weight, sometimes their blood pressure is very high. Sometimes they already have diabetes. And so you could run the risk calculator, and you might find their risk is more like 20% in 10 years, which is very high. And then we would talk about completely advising against that. So the risk on the keto diet, of course, is that if LDL cholesterol becomes oxidized, or LDL particles become oxidized. So people will say that they're not having that, and they don't have oxidized LDL, and we can test for that, of course. The problem is if they were told that none of it matters and they should just keep going, then that's why we're here. That's why we do the course, so that we can take this like rational viewpoint.
Yeah, great, David. So much to consider. And also very refreshing that you're talking about lifespan, how long you live, as well as health span, which is how well you live, because I think that is missed for a lot of people these days. Obviously, in the holistic profession, we're all thinking that way. I'm not, oh, maybe one more just came up. Okay. Okay, there's a compliment. Thank you for your talk. And could you cover holistic approaches to diagnosing diseases before they would be symptomatized in the best way? So I think possibly we're asking, diagnosing early before they actually become a disease. Are there any test that you're running that way?
Ah, I can't think of, oh, it's just a comment. Do you routine, it says it's a comment to, you could cover all holistic approaches to diagnosing diseases before they would be symptomatized in the best way.
Oh, I read it backwards. It says you could. I said it as could you. Okay, sorry about that. Sorry for the confusion.
No problem, no problem.
And
There's a question here. There's another one about, do you routinely test for vitamin and mineral deficiencies? Yes, we do. Yes, we do. So we use red cell tests from Life Labs, and the lab in Ontario Dynacare. We use those two labs for red cell levels of, for example, magnesium, and there's tests for vitamin A, and then there's we do a lot of vitamin D testing and zinc and copper, and a lot of B12, and then we do the micronutrient assessment. We do micronutrient assessments as well that are more comprehensive but much more expensive. So we have access to all of them, and we talk about a lot of them in the course.
great. Thank you so much. So it looks like we're wrapping it up here. So if you're interested in learning more about lab diagnostics, please, you can contact Colleen at IHN. That's Colleen at instituteofholisticnutrition.com if you have any specific questions. The course is laid out on the website, showing you the various sessions. And as mentioned earlier, I think the course is already half full. So if you're interested, I'd jump on that right away. Again, David, thank you so much for the informative and enthusiastic talk. And thank you also to all the attendees today. That's about it. So I wish you all a wonderful day.
Thank you to IHN for having me. Have a great day, everyone. Join the course. It's really fun.
Bye for now.